Thank you all for coming. Hopefully, we will convey some exciting stuff for you guys. I'm Dr. Seth. I'm the Executive VP at HealthEC. And the team today will present sort of our case study from DHCF in DC. Our first speaker, Kerda, would highlight the challenges the department and her own division faced and what solutions they were looking for from a business use case end. Tariq will follow that. Tariq is the data architecture guru, and he then used the information that or the problems that Kerda had raised to help design the data warehouse in the modeling behind it. And now that we have that data warehouse up and running, we've asked Juan Montanez from HMA to tell us what the future could look like once we have access to the data. And I'll try and be the goofball at the end to tell you what's really possible, what's not possible, how long it takes. But let's start with Kerda then.
Good morning. Okay. So as Dr. Seth mentioned, Kerda, Tariq, Juan, and Dr. Seth. So today we're going to start by laying the foundation, talk a little bit about the triple aim and the key challenges, the robust analytical tools that were developed, and take a look at some of our performance dashboards. And then, as Dr. Seth said, Juan will look at optimizing outcomes for the future. So laying the foundation. So of course, I'm with our Division of Quality and Health Outcomes unit, and of course part of our quality strategy, as I'm sure with most of you, is to achieve the triple aim of improving quality, better care, and reducing costs. And with that, we were looking at some key challenges. We had a lot of preventable utilizations that were going on in the district, about $53 million that we've identified as far as preventable utilization. Outreach and care coordination was another challenge. Access to analytical data. It took up to 2 or 3 weeks in order to get your data request completed. We tweaked our encounter adjudication system as we relaxed some MMIS edits so that the encounters could flow into our MMIS system. And so that was another challenge as far as tracking encounters accurately. MCO measures are, for the most part, still currently self-reported. And unknown providers, of course, that's still an issue. CMS didn't hear me say that. And we currently don't get denials, service denials from the MCOs. So the impact of all of this was that 1 in 3 district residents covered by our Medicaid program and our locally funded program through the Alliance were impacted by some of these challenges. And 75% of our residents are in managed care. We have 3 managed care organizations in the district that are full risk, and then we have 1 special needs MCO. So the immediate need that I'm going to talk about that we worked with HealthEC on was we decided to start a health home for multiple chronic conditions. We already had one for serious mental illness, and that was run through our behavioral health agency. And so we decided to look at the beneficiaries who had high ED visits, high inpatient stays, high comorbidities, and these were the ones that were really driving costs. And so the care coordination system, of course, it was close to 20% of our beneficiaries. So this was, one area that we definitely wanted to tackle. And we assigned them to 10 different providers. It was the opt-out model. So everyone was assigned. They were attributed to a provider, and assignments were made. And we had 2 stratification tiers. So we needed a care case management system that would allow us to track the attributions, the enrollments, the communications between the providers and the beneficiaries. Oh, if I get closer, yeah. Okay. To capture required documents, like if the beneficiaries wanted to change health homes or they wanted to opt out of the program, we needed a place to keep all that information. And also to track program compliance with the provider staffing. Each health home is required to have a minimum level of staffing, and the system is able to help us do that. And then also to track reimbursement for services. And of course, to report our performance measures to CMS. So we used HealthEC's care manager module to develop a robust care coordination and navigation system. I didn't name it, but that's what we call it. So it's augmented with reports from our Medicaid data warehouse that we're going to talk about. It's CMS certified. We currently track approximately 51,000 beneficiaries across the 10 health homes. And we track, as I mentioned, provider staffing by the required threshold for acuity, and document communications and monitor access to care. An additional benefit that we got from the system was that we can also create weekly the CMS 416 reports, our 9710 payment reports, MCO enrollment and care delivery dashboard. And I'm going to try, this is our delivery, the green is the lighter green is what we pay into cap payments, and then the smaller one, and Tariq, there we go, yes. And the darker green is what they've told us that they've expended. So we're able to track these through our dashboards. And our performance monitoring dashboard, you can, Tariq, in your spotlight, yes. that can show us utilization, hospital stays, let's see, by diagnoses, by procedures. We've got a multiple set of dashboards that we can look at. And then also there's an analytical portion, the 3D analytics that we use with HealthEC, that we can look by provider, the cost, diagnoses, just about anything you can imagine. And so we can analyze by health plan. Dr. Seth is going to talk a little bit more about that, but I just wanted to give you a little highlight. And track costs by utilization in health plans. And also the quality measures. We have reporting for both health homes with our data warehouse. And I believe, Tariq, you're up next. Thank you.
I've never been accused of being soft in my voice. If you don't hear me, please raise your hand so at least I can speak up. So you saw how we have implemented a solution to help manage our MCO, performance monitoring, and as well as oversight, right? Some of the dashboards. As we all know, the most difficult part we have is laying the foundation, essentially the technical enabler, which is what we did. So David, our CIO here, had set out for us a big vision in making sure whatever solution we put in is something that we can use for the next 10 years on. So we had in here stuff that identified that's for the future, like big data, predictive analytics, machine learning, that we had to incorporate in our architecture. So we started off with some of the basics, laying out some very rudimentary stuff where we would bring the data in, how we would cleanse and make that available to our users, and then what sort of capabilities we would have for our users. Moving on, that was the vision, and this is our realized solution, which as of recently has been certified fully by CMS, thankfully. And it was a quite rapid process. In fact, at the end of that certification or demonstration that we had given, the proof and the demonstration that we have given CMS, they said you ought to present at the cohorts meeting as well as at the MESC. So that's how impressed they were with what we had done, the little tiny state or district that we are. So with that said, what we had done is this. So I'll try to highlight. In fact, I'll go into magnification mode just so you can see it. What we started off with is a legacy system which had data coming in from MMIS into various EMR, EFADs, and CERS, which I'm sure most of you are aware of, right, as states. The databases and tools that allowed us to analyze our information, generate reports for CMS, and do other things. We had then taken the entire MMIS data and make now a copy in our data warehouse. So everything that's ever put through MMIS is in our warehouse, and we continue to grow it. And not just that, we bring data in from various other sources, and we house it in here as well. What we've been able to do is build an integration layer that allows us to dynamically bring additional data sets as needed, without having to, in a lot of cases, without having to do a lot of coding. And that's where HealthEC is quite helpful as well, because of their pre-developed plugins and tools. We're able to bring that in as well. That said, we are currently building on, Curtis, our PMO, project manager, is working closely with some other developers to help enhance this integration layer and make that API enabled, so that we can bring in more data sets as and when needed, as well as also supply data sets to our applications as and when needed. So that said, here are the suite of applications that we've put in as part of our data warehouse front-end utilization tools. So we have SaaS-based tools, we have Tableau, and we are big on the Microsoft BI suite. And HealthEC helped us, the 3D analytics piece, helped us bring in a lot of pre-developed reports, stuff that they have delivered and used in many other states, which I'm sure you will see a little bit. So that said, moving on very quickly. Here is the data model that we had created. So one of the big pieces that we had focused on was generating model that allows our users to be able to report without understanding the complexities of the tables and relationship and coding. So for example, I am an analyst and I'd like to perform a financial impact analysis. What would I want? Well, I want to know whether we, let's say breast and cervical cancer. We want to cut that off. How much have we paid for it? What is the average cost? What does the beneficiary now, after having received it, what does their health outcome look like? What I could do is I could start off with, I know I'm looking for procedure codes, so I could start off with procedure codes. We all know about, most of us know about modifiers, right? Which allows us to set specific rates or use it in special conditions. I can start off with the procedure modifier, link it all the way to the claim detail, link it to the member, and perform all sorts of analysis all by myself. And there are tons of reports our users have developed by themselves. And this is one of the things that we had showed to CMS when we went through the certification, which our users absolutely love. I think, there, kudos to the team, the data warehouse team that's here. And HealthEC being part of it, and our business users being the key drivers. So that data model allows us to do a lot of analysis, which you have seen before. That being said, we've also enabled self-service. With self-service, we've gone down the Microsoft BI suite model using the SQL Server analysis services. We put all of our 14 years of claim data in the analysis services in a matter of seconds. And in some cases, people, when we do the analysis and we show, people are amazed. So like, for instance, within a matter of milliseconds, I can go to look for every beneficiary and their total claims, who's cost us the highest, switch that out, and put provider information by billing provider, by rendering provider, by referring provider. Not only can I do that, I can do combinations of it. So I can pull in member information as well as provider information. So in a snapshot, I could see immediately in a matter of milliseconds, and you'd have to see it to believe it. I think we'd done a brief demo in the cohorts meeting in January, at the end of January. So if you're more interested, we are around, David, myself, Curtis. Talk to us and we'll probably arrange a demo for you. In fact, Tennessee wanted to see a demo as well, and a few other states. So that being said, I'm not going to bore you with all the things that we possibly can do, unless if you have any questions at the end, we can tackle that. The other benefits that we have realized from this solution, going back to optimizing the outcomes, is being able to understand the utilization. So from program integrity, So from program integrity perspective, being able to review all the utilization, the payments that we've made, and being able to shortlist those outliers, right? That's primarily what program integrity is looking for. And be able to audit, focus the audits on only those that they need to. And then we had performed Paris interstate match. The best part of this was, I think our project cost roughly in total, I think $12 to $15 million. But the first year that we did the Paris match, we've saved more than $6.5 million, being able to cut off those payments to beneficiaries that had moved to other states, but we're still being paid capped for to the MCOs, right? So those are things that we've been able to do. Waiver program, that's huge. Every quarter it used to be an exercise, a project, so to speak, being able to extract the data, run the reports, understand what the neutrality is, whether we are over, better cost neutral, and so on and so forth. What we now have enabled our users is on a weekly basis, refresh the waiver expenditure, the 372 that so CMS requires us to report. And then a few other things, like we're able to do eligibility and enrollment reviews. People that are categorically eligible and we want to move them out. We produce reports on a weekly basis now, are able to pass on to other agencies that take care of eligibility so that the eligibility could be updated. So at the end of 12 months, the child that's born to a Medicaid beneficiary has to be now put through a proper application intake process, right? So those are things that we've done. We're also working on substance abuse disorder dashboards and a few other things. So with that, I believe I'll stop. I still have 2 more minutes, but I'll let Juan take it over.
Thank you. And I like that gadget. I got to learn how to use that thing. I'm with Health Management Associates, a consulting firm that has worked with the district, as a matter of fact, on the Health Homes 1 program, but across the country on a number of different initiatives related to healthcare reform. I am with the IT Advisory Services Group that has helped design and implement and plan for solutions like the one that Tariq and Kerda just described. My role here is to, I guess, make the transition from what has been implemented in the past to what could be implemented in the future around performance management. And the theme might be MCO performance management, but in fact, that same infrastructure, that same technology can be used to manage any kind of program that a Medicaid agency might want to deploy. You can evaluate the performance of ACOs, of integrated delivery systems, of health homes, or whatever acronym you want to use to describe the provider-led entity that you might be testing or modeling in a particular state. The same infrastructure can be and should be leveraged to support the evaluation of all those different types of programs. I am officially retiring this slide with this presentation because I've used it in like 13 others. So for some of you might have seen it before. I might want to use that magnifier, but I'll probably break it if I try to use it now. But the gist of it is that we are dealing, as we all know, with a very complex environment of systems that are being used across the entire ecosystem of providers, payers, regulators, agencies, from public health to MCOs, to the providers that have EHRs and their own administrative systems and their own business intelligence systems, the various state agencies, whether it's Medicaid, whether it's behavioral health, they have their own systems for managing the clinical or the service delivery side of the operation versus the administrative side of the operation. Bottom line, we need technology that can aggregate, that can extract, transform, and aggregate information from all these different sources in the most efficient way possible that reduces the burden on staff and on the suppliers of the information, and can then enable you, liberate you literally, to create all the cool dashboards and other ways of visualizing and presenting information that Tariq just showed you. We are at that point in time in the evolution of this technology where that is much more possible. And it's needed because, as we all know, the world of performance management, whether you're dealing with MCOs or ACOs or CCOs or RICOs or what have you, is very multidimensional. You're trying to gauge how well these entities are doing across at least the 14 dimensions that I'm showing you here, from HEDIS measures to child care measures to adult measures, EPSDT, which DC showed an example of, incidence and use rates, all the way down to how well these entities are managing performance improvement projects, how satisfied are their members, their providers, their staff in some cases. Access measures are critical, how timely they're reimbursing providers, the solidity of the finances of the entity, and just getting a good sense of the operations of the entity. So that's a lot of measures. It could be hundreds of measures in some cases that states are wanting to have a good feel for. So how do you assimilate all this information, digest it, and make it useful is, needless to say, a significant challenge. How that has been traditionally accomplished is all states like to get encounter data from their entities, their MCOs. Increasingly, you're seeing greater use of clinical data, which obviously resides in EHRs, care management systems, and other systems of the like. And then, well, files, and more files. There are still states that are asking MCOs to submit data in CDs. There are still states that are asking for all these custom reports that when you really get down to it, all originate from the same core data. They might be derivations of encounter data, they might be derivations of clinical data. So to the extent that you could simplify the process and reduce the burden on staff at these different entities and just enable them to submit more raw data, and then you have systems like the ones that were just shown that can make something out of it, you're making it easier for you to extract meaningful knowledge out of it, and you're relieving burden on staff at the source entity, which will probably make it more likely for them to actually send you data. You'll get less resistance in the process of submitting data. So what we've seen and what we're trying to move away from is heavy reliance on data that's supplied at a fairly aggregated level in many cases by the source, which limits your ability to go deeper, to slice and dice and mine the data, do root cause analysis and so forth. Of course, you have lag, which we all recognize is always going to be a problem when you're trying to be more up-to-date, more proactive in trying to identify a problem and trying to resolve it. You have a wide spectrum of reporting requirements, which sometimes don't quite align. And we all know the challenge of measure harmonization still exists. So you're dealing with inflexibility in terms of the source systems and your ability on your end to be able to digest and make something out of that data. And I love my policy folks and I love lawyers. I want my daughter to be a lawyer. In fact, she wants to be a lawyer, so I'm really supporting that, even though it's going to cost me an arm and a leg. But if you expect lawyers to be able to develop fancy performance measures without input from folks that understand the data, it can be a challenge. So it's always good to have collaboration, the policy folks, the JDs that are writing up these masterful contracts, and the people that then have to make something out, those very crafty and creative requirements, to be able to figure out how are we going to get that data, source it, and turn it into something meaningful that meets the requirements for that particular measure. Again, some of this, not surprising, we're trying to deal with the challenge of reconciling data from multiple sources. We're trying to make it so that we can take timely action, and you can't if you have data that has months or even years of lag in some cases. Because of limitations in technology in the past and bandwidth in the present, you're sometimes only able to manage a limited set of measures, which doesn't really give you full visibility into how well these programs are performing. So to the extent, again, that you can make it easier to consume the data, it liberates you to then be able to do more sophisticated measurement systems. The end result, historically, we have had some challenges acting promptly as regulators, as payers, to be able to meaningfully act on observations that can be derived from that data. So how do we deal with that? How do we solve the problem? Well, we certainly want IT solutions that, to the maximum extent possible, can improve the ability to perform all of these functions. This is the whole life cycle of data, from aggregation to synthesis to transformation, loading, and so forth, in as streamlined a manner as possible, to not have staff have to manipulate data, which we know happens in every state. For a report, somebody has to go in, extract data, massage it, tweak it, drop it into a spreadsheet, turn it into pretty diagrams. As you saw in the DC example, you want to make it so that the user has that self-service capability without having to go through all those manipulation steps. And if properly architected, these same solutions that could be initially deployed for an MCO performance management program could be used for a health home performance management program, an ACO performance management program, and that same infrastructure could be made available to the providers operating within those MCOs, within those structures, so that they have an easier time managing their own performance. And it's all based on the same data. So you're going to get consistent analysis and consistently applied actions as a result of that data that you now have aggregated and accumulated in one source. Again, what are we trying to accomplish? Independent validation of MCO performance, where you're not necessarily relying on the MCO to compute the measure and give you something that you really can't do much with because you can't drill down, you can't dissect and mine the data. You want to have the ability to do that yourself. Of course, you want to give the MCO or the ACO the ability to challenge if they think that what you computed based on what the supplied is not exactly in line with what they think is their performance. But if you're working off the same data, that you can both go deeper into, it makes it a whole lot easier. It'll improve your monitoring capabilities, fraud and abuse, which was briefly mentioned in the DC presentation. You can actually create performance improvement projects and initiatives that are specific for an MCO. A theme that I want to leave you with is, and this is not something that I made up, this is a phrase that has been used by many others going back to Greek philosophers, is there's nothing more unequal than the equal treatment of unequals. If you're dealing with multiple plans, Kerda brought up the example, you have 3 more traditional MCOs, then you have a special needs MCO. In some states are MCOs that are really designed for kids or older adults. You don't want to use the same measures to manage the performance of all of them. You want to create tailored measurement systems that meet the expectations that you place on those different types of entities. And of course, we all love having fully certified platforms because, of course, we love that federal money. So what's the ideal end state? You want to have, again, the ability to leverage those source systems to the fullest without imposing burdens on the supplier of data to create all these custom views and all these custom packages of data that all work off the same source. If you can digest the source data in a more raw form, it makes it easier for them to send it to you, and it makes it better for you because you can do more with it. Again, the automation of the whole data management process from end to end, automated visualizations, and here's where you start getting into being able to drive actions based on the data, have the systems flag you, not to death, because that happens too, but to give you targeted alerts based on certain thresholds being met or not met, and those thresholds, those alerts would go to the right users that can then take actions based on that. Frankly, Tariq's diagrams are prettier than mine, so I will just show you this very quickly. The ultimate goal is to create these dynamic balanced scorecards, Norton Kaplan, multiple dimensional performance. You can use weighted metrics to then come up with dashboards or composite views of performance. You want to be able to, of course, move up the performance management progression spectrum. You want to go from being unaware to aware to inform to predictive and ultimately proactive, where you can apply machine learning and artificial intelligence. This is, of course, very futuristic, but it's starting. You see a lot of articles now about different organizations applying artificial intelligence and machine learning to, again, it's all about liberation. It's about making it easier for you as the user of that information to make something of it and remove the burden of having to manipulate and spend hours and days cleansing and scrubbing and making something out of data. Yeah, I have to throw some animation in there for good measure. Trying to keep up with the young people in DC. So, and then lastly, as I mentioned before, this notion of flexible, tailored performance management protocols. Tailor the protocol to the specific requirements that you're placing on these entities, which are serving different populations, have different expectations based on them. When you're bringing in a newer MCO or a newer provider-based entity, you might want to cut them a little slack. Let them build up capacity and capability, and then over time, you move them towards graduated targets. The more veteran plants, the better established entities, you probably want to start up front with more aggressive targets because you would expect them to be able to meet those targets. So again, you want to have the ability to, working off the same data, create these customized performance management protocols. So to make it all happen, what are we talking about? Well, it would be nice if states could take a step back, knowing that the technology is there or almost there, to let them create the performance management system of their dreams to fundamentally rethink their approach to performance management. Again, MCO could be replaced with any acronym you like. That way you're setting the stage for leveraging that ideal end state, that balanced scorecard with dynamic measures where you're tailoring the target, the goal to the individual program or type of entity that you're managing. You definitely want to secure stakeholder buy-in. I mentioned before, again, nothing against the lawyers and the policy wonks, but you want to get them in the same room with the data analysts and the IT folks so that as you're developing those new measurement systems, you know that it can be implemented, ideally from day one, by leveraging that technology. And let's not forget, you want to have the entities, the MCOs, the ACOs, the CCOs, the RICOs, the IOs at the table with you too. Make the investments in technology and resources. I'm sure CMS will support those, especially if they're actually deemed as modular. And by the way, this same technology can also be deployed across health and human services. You're not only limiting yourself if you use the right technology to Medicaid or public health. You can go beyond behavioral health and then beyond into social services and use that same platform to assimilate data that can let you also look at social determinants as an example. And then finally, take the opportunity to revise those contract requirements. Make those contracts speak to the performance that you want these entities to achieve, along with those flexible, tailored performance management protocols that we talked about. So that's my part of the presentation. Thank you.
Thanks, Juan. I'm going to try and wrap it up and then open the floor up for questions. But some of the things that we've talked about that Juan mentioned is that you don't want to be in a steady state. You don't want to be executing contracts that are everlasting. You want to be dynamic. You want to be the entities, the agencies, the programs to be responsive to the needs that they are seeing through data. All of us work off our gut feeling, and we've heard a lot about gut feelings, but it's time that we don't use an intuitive process. We should support that with data. And we always have a hypothesis that we want to go with and then validate it. Now it's not a one-year PhD thesis. It's a few minutes that takes the data and manipulates it. The things that we've been talking about are reports that make it dynamic, that make it available to you immediately. And that changes policy, that changes contract terms. We've all started to see that in the normal world, in the commercial world. It needs to translate back into the state agencies. I mean, self-insured groups retool their entire contract every year. Why do they do that? It's predominantly to try and save money, but they're seeing a different pattern. They're seeing more employees with a certain condition, preventive stuff. So without having these tools available, and as everybody you heard today saying that data is data, you need to convert that into information and then learn from it. So it's knowledge. So you got to go through the 3 steps. You get the data, you create it, make it, transfer it into information, and use the information to develop knowledge. So that, and you can't take 10 years to do that. It has to be done quickly. So as Juan and I are maybe one generation older, we're struggling with technology. But what we are beginning to see is that this is now ready-made available. And so I'll leave it up to the group for questions. Anybody have any questions? I'm going to answer them all, so don't worry. But go ahead. Let's have a question. Anything. You can talk about the wall. It doesn't matter. So either you've understood everything or nothing at all. Come on. No questions? How long does it? Yes, go ahead.
How repeatable is the solution that you built? Could another state How repeatable is the solution that you built? Could another state just copy this, or would it be a custom project?
The system that you saw, or the infrastructure with the business use cases, is absolutely repeatable. It is deployable quickly. One of the easiest things that we all figured is how long it takes to do all of this stuff. If I throw a number out, all of you are going to fall off your chairs, because it is no longer a multi-year project. This is a multi-week, multi-month project. So everything is modular. It depends on the state that the state is in. Do they have a valid data warehouse? Is it of digested material or raw data, as Juan was saying? Without having raw data, then you start to limit yourselves. So some of those predeterminant factors may make the timeline stretch or shrink. And so it is absolutely repeatable. This is, Tariq, you want to say that?
I might as well stand next to him. A few times I get stand next to him. So to your point, I didn't catch your name. Did you say your name at all?
No, I didn't say my name. My name is Yorick Schwartz.
Yorick Schwartz, yeah. So Yorick, what we have done is there are 2 pieces to this puzzle. There is the piece that is the COTS application, which, right, the HealthEC is part of. And there's a piece that we have as states, David Shop owns. That piece is pretty much reusable. Like we said, we have heavily invested in Microsoft platform and also in SaaS. So from reusability, there are a few things that you could reuse. In fact, that's something that we had worked with CMS on to try and make sure that's available to other states. Number one is the data model itself. So the data model by itself, you have shell, logical model, or the physical model, we're able to share that. So it could be SQL. So any SQL that you want to convert that into, it's relatively easy to pull it into, right? So at that point, what we've done is thought through what uses can be generated from it. So that's the reusable part of it, right? So like, for instance, I can do accruals, I can do fiscal impact analysis, I can do weekly payment analysis, all sorts of analysis from the data model itself. So that's fully reusable. Being able to populate the data into the model, as we all know, each of our MMI system varies. Each of our source data varies. So that piece has to be written, codified, as you say, right? So that part, we're happy to share our ETL. We're happy to share, I'm sure, again, talk to David, a lot of things that we've done. So because it's all paid for by CMS dollars, right, from in-house built versus what's available in COTS. That ETL, as much as you're using a conduit mainframe-based system, the tables, we are bringing in the entire 400 plus tables into the system. We have written an ETL for it. If you have the same system, same rules, it's relatively simple to then take it on. And then the third piece, which I think is crucial aspect of it, is from that model, we have generated a whole lot of reports that we all need as states, like CMS 416, right? We need that. Screening, well child visit screening or lead screening or all of these things, right? In DC, we have Salazar Act, which requires us to do a lot more, but leave that alone. That logic is built on top of the data model. So if you were to take that logic, so you have the data model that you're using. Now you want to take the logic so that you can see now which procedure codes or revenue codes or program codes or whatever that is that you're using. That's reusable too. So like from that perspective, most of our reports that are CMS facing, in my opinion, biased I might say, is reusable. And then there are also other things like the PI outlier detection, right? Again, if you are in the same mode, you're able to leverage it as well. To me, the biggest advantage, which I think some of you may be interested in seeing perhaps, is the self-service capabilities. We call it the DAX, right? So Microsoft has DAX, Data Analysis Expression. That's SQL Server Analysis Services. The entire DAX is XML-based. So you could simply take the model, you have the data model, you take the DAX, you put it on your server, feed the DAX model, the analysis services model directly from the data model, then you're able to, on the fly, perform analysis, which, if you guys are interested, we can arrange for, I'm sure. Like I said, we talked to David, as states. And you will be quite surprised how quickly it allows us to pull data in and swap stuff out all the time. Like I can go from a drug analysis on how the users, what's the most used drug, switch that completely to which drugs are used by which users, which beneficiaries, and then switch or add to it by payment date, by provider. And again, it's believing is receiving, right? I can talk here all day, but those pieces are reusable, to answer your question.
Thanks, Tariq. Any other questions? All right. Thank you all for coming. And we are here for questions.